This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 13, Disorders of Glucose Metabolism. Key concepts. Upon completing this chapter, you'll understand multiple hormones keep blood glucose levels within a specific range. Blood glucose levels can be a medical emergency, leading rapidly to convulsions and death. High blood glucose levels lead to alterations in fluid and electrolyte levels, causes confusion, shock, cardiac dysrhythmias, and death. Diabetes mellitus is the usual cause of glucose metabolism abnormalities, although medication, physical conditions, and environmental factors can also alter glucose levels. Chief concern. Glucose is essential for brain function. The body must maintain a steady supply. Too much or too little is detrimental. An overview of glucose metabolism. Carbohydrates are our main fuel source. We have two forms of that. They are simple and complex. Simple carbohydrates are found in foods such as fruits, table sugar, and milk. Complex carbohydrates are derived from vegetables, nuts, and whole grains. Glucose, the main substrate of energy production, changes in the circulating blood glucose levels can have a significant impact on neurological and cognitive functioning, and there are several terms here that you need to be aware of, catabolism being one of them, which is complex carbohydrates such as starches and cellulose are broken down into their simple sugars. So even if we get a complex carbohydrate, it goes into the system, we can very easily turn it into a simple sugar. Glycogen, chemical compound composed of long chains of glucose molecules connected together. And glycogen is stored primarily in the liver. It's also stored in the muscle tissue so that they have extra glucose supply. And we put together glycogen from dehydration synthesis. So the simple sugars then are put into chains, and then they form a larger molecule called glycogen. Lipogenesis, the creation of triglycerides from fatty acids and glycerol, which are in turn bound to high-density lipoproteins. Glucagon, production of alpha cells in the islets of Langerhans, and the islets of Langerhans has three cells: alpha, beta, and then delta cells. Alpha secrete glucagon. Beta cells secrete insulin. And the delta cells secrete somatostatin. And this is our supply, our chains of sugar. The insulin allows it inside the cell. It facilitates the diffusion of the glucose. And somatostatin puts the brakes on I need sugar. So brakes allow into the cell, and then the storage unit, or the chemical storage unit for the glucose. Glycogenolysis. Glucagon, which is from the alpha cells, breaks down glycogen to its component, glucose molecules. So very simply, like I said before, the glycogen is in chains. The alpha cells secrete a hormone glucagon that busts apart the chains and makes available sugar for us. Gluconeogenesis, process of breaking down fat into three fatty acids and glucose. Easy way for the body to produce glucose in case it needs to make it. Ketogenic pathway, glucagon helps convert free fatty acids into keto acids and other ketonic bodies, which in turn are metabolized in the liver into energy. A range of blood glucose levels, while we're talking about this, about 70 to 80 milligrams per deciliter. High normal is 120 to 140. Blood sugar over 120 to 140 is considered elevated. Patients can have transient versions of this to have blood sugars over 180 to impaired glucose metabolism. Impairment in several organs or their hormones can result in significant disease, thereby causing considerable health consequences. And we're primarily talking about things like the liver, the pancreas, islets of Langerhans, which is a section of the pancreas. Those are the hormones that need to interact appropriately. Any inappropriate interaction between those hormones and other cellular bodies would be a derangement, so a type of diabetes. And this is glucose metabolism, figure 13.1 in your book. So we have glucose here, and then the insulin allows the facilitation. It opens this up to where the glucose can come right inside the cell. Without insulin, glucose will not come inside the cell. Now, once this glucose is in the cell, we turn it into pyruvic acid, and then essentially run it through the Krebs cycle to formulate energy. So this is a key component of our energy production inside the cell. We make about 2 ATP molecules without oxygen. Glucose is a major component of the energy formation of ATP. Diabetes mellitus. Type 1 diabetics are insulin dependent, which means they have a lack of insulin or they produce no insulin by the pancreas. The insulin types that they have, there's over 20 different types of insulin. There's rapid, intermediate, and long-acting, just branched into a couple simple groups. Insulin administration. Most common form of it is injection. They do have people now with insulin pumps. It's an external device that holds a volume of insulin in it, and it progressively, essentially, sends insulin into the fat tissues through a Teflon catheter. Now, this continues to pump in insulin continuously. So if a patient like that had a hypoglycemic event, and hopefully there's someone on scene that knows how to actually work it, some of them are locked down, very simply remove the insulin pump source until you can adjust their blood glucose levels. Type 2 diabetics are different. They suffer from insulin resistance. Their body does not like the insulin that they make. Now, even though a type 2 can be put on insulin therapy, but that is to essentially overpower the cellular environment. Treatments of a type 2 diabetic include diet modification, exercise, oral hypoglycemic agents. All are in form of treatment, and they can even be on insulin as well. Diabetes mellitus continued. Gestational diabetes is an elevation in a woman's blood glucose levels, and generally this begins during pregnancy. Most resolve their hyperglycemia after they give birth. Undiagnosed or poorly controlled diabetes during pregnancy causes major birth defects in about 5 to 10% of the pregnancies. Prediabetes, chronic hyperglycemia that does not reach diabetes, has many of the same complications. Complications of diabetes, abnormal metabolism secondary to diabetes, can have a number of negative systemic impacts, including disease in the cardiovascular system, neurological system, and renal systems. Hyper and hypoglycemia, the effects. Whenever we are hyperglycemic, we get the polys. So we get polydipsia, polyuria, and polyphagia. Polydipsia is increased thirst. Polyuria is increased urine production. And polyphagia is I'm hungry all the time, constantly hungry. Diabetic ketoacidosis, characterized by profound hyperglycemia, severe dehydration and acidosis, and mental status changes. Physiology on this we'll talk about here in just a second. This is figure 13.4, and on the next slide we'll talk about diabetic ketoacidosis. We have something called hyperosmolar non-ketotic syndrome, or non-ketotic hyperosmolaric acidosis. Some may have extremely high blood glucose levels, which would be greater than 600 milligrams per deciliter. Most of the time, your glucometry will just say high on these patients. They don't typically become acidic, and they may not produce ketones at all, or and they may not have ketotic acidosis. Thought to be a result of pancreatic failure coupled with renal insufficiency. And this is table 13.3, and we'll look at it right after the next slide, DKA versus HONGS. Hypoglycemia, serum blood glucose levels less than 50 milligrams per deciliter. Causes of this, we frequently see this whenever the patient has a complication of their diabetic treatment. So they forgot to eat, they mismanaged their sliding scale, or misfigured their sliding scale and have overdosed themselves with an insulin dose without an ample supply of carbohydrates. Special cases on this are things like alcohol ketoacidosis, or AKA. Patient presents with signs and symptoms of the DKA, yet is hypoglycemic. Distinct syndrome seen in patients with a history of chronic alcoholism. Pathophysiology on this is not completely understood. AKA, or alcoholic ketoacidosis, is a competition with the liver between metabolism of the alcohol and the production of glucose via glucose neogenesis, is their best guess. They're still not completely understanding the whole pathophysiology pathways on this, though. And this is DKA. Insufficient or absent insulin, so the body is essentially going to break down anything it needs for energy, amino acids, glycerols, fatty acids, and convert it into energy. Now, the byproduct of the fat metabolism is going to be ketones. The higher amount of ketones that we have in the blood supply, the higher the acidity levels in the body, or the lower the pH. So in the overall scheme of things, the ketoacidosis, the more ketones that we produce, the more acidic we become. This is table 13.3, DKA versus HONGS. Variations here. So DKA, generally median onset is about 40, where HONGS is about 60. Neurological deficits in DKA are uncommon, where in HONGS, hyperosmolar, they are common. Nausea and vomiting, common on DKA, but uncommon in HONGS. Cramps, common in DKA, but uncommon in HONGS. Shortness of breath, common in DKA, but uncommon in HONGS. And each one of these has a cause. Neurological deficits, alteration in high acidity levels, denature things. Nausea and vomiting would be caused from the systemic release or systemic high blood glucose levels and acidity. Cramps, same way. Dehydration of the muscular area, shortness of breath would be because of Kussmaul's respirations, trying to alter the acid-base reaction back to normal. Thirst and dehydration are common in both of them because they are dehydrated. History. Considerations. Suspicious of a diabetic emergency should be based on the presentation. Hypoglycemia is an important element, and one of the important elements of it is the time that they had their last meal. In diabetic ketoacidosis, symptoms, classic triad of the three polys, polyuria, polydipsia, and polyphagia. Causes of this could be from an infection, noncompliance with their insulin regimens, or undiagnosed diabetes. On examination, it's important to measure their blood glucose values, the amount of glucose circulating through the bloodstream. We do this with a glucometer. Several factors do, however, affect the glucometer and its accuracy and performance, and those include altitude, humidity, and possible ambient temperature. So if it's really, really cold outside and your glucometer is near frozen, it may not provide accurate results. Hypoglycemia, symptom pattern associated with hypoglycemia as a result of a release of catecholamines such as epinephrine. Now, the neuroglycopenic symptoms result from sympathetic stimulation. The hypoglycemic unawareness patient with chronic diabetes may not present with classic symptoms pattern of catecholamine release. Normal response is blunted, and the patient may not have recognizable signs. So if you have an altered mental status, always check their blood sugar as a point on this. In DKA, or diabetic ketoacidosis, symptom pattern is a result of dehydration and acidosis. In HONGS, or hyperosmolaric non-ketotic syndrome, presentation of the patient is one of profound dehydration without ketosis the pancreas is still secreting a minimal amount of insulin, so that's why they don't start producing ketones. Key finding that should raise suspicion in honks is altered mental status and extreme hyperglycemia. Now, very simply, a type 1 is probably going to be in DKA. A type 2 diabetic is probably going to be in honks. Not always, but it is suggestive. Those are other key factors, the history of the patient's actual illness. Assessment. Diagnosis of glucose metabolism disorder, hypoglycemia or hyperglycemia, and this should be based on accurate history and physical. Honks and DKA. DKA's mortality rates are as high as 20%, and honks mortality rates are as high as 70%. So the person that is hyperosmolar coma is much more sicker than the person that's DKA. Treatment for the hyperglycemic patient cannot be resolved in the field. The paramedics must be prepared to treat associated complications, care supporting efforts to compensate for effects. So just general supportive care for them and get them to a place they can readjust all of their electrolytes because they are an electrolyte train wreck. Hyperosmolaric non-ketotic syndrome. Pre-hospital honks and DKA treatment are essentially the same. Airway management, IV access, and saline boluses. Convulsant treatment if the patient is seizing, and that would be through standard benzodiazepines or things like Versed, Valium, whichever is in your local protocol. And then coma treatment, primarily airway management. Diabetic ketoacidosis treatment, vomiting, suction, and preventing of aspiration. As far as ventilation goes, be sure that you are adequately ventilating the patient. Fluid bolus administrations, electrolyte imbalances, heart function, increased distal perfusion, all of those should be attempted with the fluid bolus. Hypoglycemia, immediate glucose treatment. There's some drawbacks to this. If we administer orally, as soon as we administer the glucose orally, the pancreas dumps a bunch of insulin, which may have just decreased our efforts as far as treatment. Intravenous access, changes in the venous blood vessels, secondary to diabetes, intravenous access can be difficult to obtain sometimes. Glucagon administration, if the patient does not have IV access, or if attempts at IV access with significant delay in therapy. And then thiamine administration. Now, there's a debate on the thiamine administration in the medical communities, medical versus pre-hospital. Patients who are thiamine deficient due to malnourishment are at risk at developing Wernicke's encephalopathy. Not administered routinely, the thiamine isn't, unless it can be established that the low blood sugar is due to prolonged starvation or malnourishment. Another patient that fits into this category would be the chronic alcoholic. Evaluation, hyperkalemia, complications of DKA, leading cause of death, and we should think that this is occurring whenever we have peaked T waves noted on the EKG or without any ST segment depression. And if we see that, competitive electrolyte use may be ordered as well. Depending on your standing protocol, you may be asked to give calcium gluconate or calcium chloride in this matter. Disposition, transport to an emergency department, controversial decision on actually transporting with a hypoglycemic patient. Key issue is the patient's ability to rationally refuse transport. And very simply, we should take an ABC approach on this. Affect behavior and cognition. If our treatment looks effective, if their behavior is back to normal and they are cognitively aware of their decision, then we should uphold the patient's rights. Cause of low blood glucose may not be apparent in some cases. Insulin-dependent diabetic patients with resolved hypoglycemic treatment transport to the emergency department for evaluation. And we should be looking for the cause of the low glucose level. This may not readily be apparent. If they have an infection brewing, we'll never see that in the field. Pediatric considerations should also be taken as well. Table 13.5, which we're fixing to look at,
is alterations for pediatric administration of glucose. And this would be variation of dextrose solutions. This is what we normally give. This is half strength. So for pediatric considerations, on half strength, we squirt out half of the dextrose and mix it up with half normal saline and shake it vigorously to be sure it's all stirred up. 2 to 4 milliliters per kilogram. Of D50, 1 to 2 milliliters per kilogram. D10, 4 to 8, and then D5, 8 to 16 milliliters per kilogram. So in all actuality, if we had a bag of D5W, we could administer 8 to 16 milliliters per kilogram via IV bolus and get the same results. Dextrose is dextrose to the diabetic. In conclusion, recognition and treatment of hyper and hypoglycemia begins in the field, and it can have significant impacts and outcomes. Definitive treatment usually takes place in the hospital setting. Some episodes may be treated in the field. It's important to review your state and local protocols in this manner. References for this are taken from Professional Paramedic Volume 2, Medical Emergencies. If you have any questions concerning this chapter, feel free to contact me. My name is Roy Smith, roy.smith@redlandcc.edu, or 405-219-7613. Thank you.